Oh. Good afternoon, everyone. Today's session is going to be really helpful and it's led by Dr. Sailaja. She is going to talk about first trimester screening. So stick around until the end and ask us questions if you have any. Let's not keep you waiting any longer. Doctor, you have the stage.
Yes. Good afternoon, everyone. Hello, I'm Dr. Shailaja, fetal medicine consultant, Apollo Cradle, Marathalli. Today, I'm here to talk about first trimester screening, the universal screening that every pregnant woman has to go through it. I chose a very simple thing, simple topic because there are so many whys, ifs, don'ts, and do's, and all those questions I thought I could cover in this topic. Was I audible? Today, my topic is prenatal screening and diagnosis of aneuploidy. Why prenatal screening? Who should be tested for prenatal screening? How to go about the screening? I would like to talk about the concept of screening, the different types of screening models and their efficacies, what to do when you get a certain result, screening in multiple pregnancy, and also talk about the non invasive prenatal testing who and when do you need to do non invasive prenatal testing, and a take home message. This is what I'm going to talk about today. Prenatal screening is generally we do a screening to rule out the most common chromosomal abnormalities, that is the Down syndrome, the T18, T13, and other aneuploidies preeclampsia. So this is a slide that is showing different chromosomes 1 to 23. Uh, this is T21. I'm talking about the Down syndrome more because that's the most commonly affected. And when instead of having two chromosomes, if there is an extra chromosome that comes and sits, then we call it as trisomy 21 or Down syndrome. Similarly, when it sits near the 13th chromosome or the 18th chromosome, we call it as a trisomy 13 or trisomy 18, and they're associated with certain abnormalities. That is why we're concerned about it. There are 6 W's and the H of Down syndrome screening. Though it is first trimester screening and screening of other aneuploidies, I am stressing a little more on Down syndrome because of its probability and because of its high risk in pregnancy. Why, when, who, which, what, where, and how is it done? Why screening for Down syndrome? Because Down syndrome is more common, and uh, Down syndrome is associated with mental retardation in greater than 95%, congenital heart diseases in 30 to 40% of the babies born with Down syndrome, GIT atresia are seen in about 20%. There is hypotonia, learning disabilities, Alzheimer's, and leukemia is also 15 to 20 times more common. There are various health risks for people born with Down syndrome, like congenital heart diseases, GI problems such as obstructions, celiac disease, problems with memory, judgment, and concentration, hearing conditions such as sensorineural hearing loss, eye problems such as cataracts and farsightedness, and some thyroid conditions. 50% of the fetuses with Down syndrome are viable. Of them, 60% of them can be structurally normal on the scan and when they're born. maybe they might have typical phases. Ultrasound alone cannot pick up Down syndrome with accuracy. The incidence of Down syndrome is 1 in 600. That is the reason why this first trimester screening has so much importance, and it is very important to do, because ultrasound alone cannot pick up, because 50% of them look normal and 60% of them are structurally normal. Down syndrome statistics. Life expectancy with people with Down syndrome has dramatically increased from 25 in 1983 to 60 years today. 79% of the parents state that their outlook on life is more positive since the arrival of the child, and 99% of the Down syndrome reported being content with their lives. But strategies of prevention. Primary prevention, avoid late pregnancies and pre-implantation diagnosis. Secondary prevention, informed choice. We can do further screening, doing a CBS or an amniocentesis with screen positive patients, and give them an option for termination if it is found affected. Whom do we offer? I mean, this is a question that uh, very common amongst people. I'm young. Do I need to do this? Is a particular set of people are supposed to go with first trimester screening, and is there a set of people that we can avoid? Is it okay to screen only elderly women? Yes. The risk of Down syndrome is directly related with the maternal age. The risk of Down syndrome increases with the maternal age. So at 25 years, 1 in 1250 babies have the chance of having Down syndrome is 1250. At 30, it increases to 1000. And sorry, and at 35, the risk is 1 in 400. And above 40, it is about 1 in 100. And when it reaches 45 years, the risk of Down syndrome is 1 in 30 babies. So advanced maternal age is a very strong epidemiological ring, zero point 0.6 to 40 per thousand between age 15 and 45. What is the basis? Ideal scenario is, I would say, every pregnant woman, because the risk is there. Yeah, as the age increases, definitely the chances of Down syndrome increases, but there is a risk even at 25. Definitive diagnosis to be offered to all pregnant women. That means you have to do karyotyping. You have to do an invasive test where a fetal tissue is required. And when you are doing an invasive test, the risk of miscarriage is there. It is slightly painful procedure. It needs counseling, and it's an expensive procedure. So do we have a more practical approach? The practical approach is personalized risk for aneuploidy and invasive diagnostic testing to high risk mothers alone. So, when you do the first trimester screening, you categorize them and place them in high risk, intermediate risk, and low risk, and then only subject the high risk women for invasive testing. Prenatal screening. How does screening work? So you subject all the pregnant women for the first trimester screening, and then you have it like a sieve, because they go through different procedures like biochemical markers and the NT scan, and then you will categorize them. And some of them, the low risk people are ruled out, and then the intermediate and the high risk people come, and then you do further testing and to check, and then you can, and then you have a further product where more high risk patients are there, high risk mothers are there, they can be subjected to invasive testing. That's the concept of screening, because you're trying to exclude as many women who does not need invasive testing. What are the different filters? One is maternal age, like I've already discussed, as age is directly related to the as the age increases, it is directly proportional to the risk of Down syndrome. Maternal serum biomarkers and fetal ultrasound markers. There's a screening dictionary that we use certain words and certain things to categorize and put them into a certain risk to calculate the risk. They are the markers, the a priori risk, MOMS, likelihood ratios, the screen positive rate, and the false positive rate. What is a marker? Anything that is found more frequently in a fetus suspected with a particular condition than in normal fetuses, therefore helps pick up the condition. A priori risk. Every woman, like I've already said, every pregnant woman has a particular chance or a risk for the fetus to be affected by a chromosomal defect. Like maybe at 25, if the risk is 1 in 1500, at 41, it is 1 in 20. So the risk still remains that whatever the risk at that particular age she carries remains as the a priori risk. A priori probability. There are certain things that are taken as a probable things, like one is maternal age, one is gestational age, which is either calculated by the CRL, the BPD, or the embryo transfer, or maternal demography. These also affect the a priori probability. This is another slide showing the estimated risk for trisomy 21 in relation to the maternal age as the gestational age and the age and the maternal age, the risk of trisomy 21. Demographic pretest data, maternal weight. There are certain factors that will also affect. Serum markers values are lower in heavier women. Afro-Caribbean race, certain markers are increased. Similarly, in IVF pregnancy, because of dating and HCG injections and donors' age, the HCG is increased to 10%, and the estradiol and the other placenta papae is reduced. Insulin dependent diabetes, the AFP, and the estradiol is less than. Previous Down syndrome, any pregnant mother with the previous Down syndrome will have a higher probability with an a priori probability increases, and smoking as well. Moms, this is a patient result by median result. This is calculated by the laboratories to give us the risk values when we are doing the biochemical markers, likelihood ratios. These are all different. The markers, the moms, and the likelihood ratios, these are different things that are taken to help us to calculate the risk and tell us what is the risk of that particular mother having a baby to have a chromosomal defect. So likelihood ratio, example, EI's echogenic intracardiac focus is found about 28 to 30% with Down syndrome fetuses in relation to 4.4% of the normal fetuses. So the positive likelihood ratio becomes 6.4. So as EICF increases, the a priori probability by a factor of 6.4 increases. So absence of the markers reduces the risk by 25%. Application. If the likelihood ratio is less than 1, the test result is associated uh, greater than 1, it is associated with the disease. And if the likelihood ratio is less than 1, the test result is associated with the absence of the disease. If it is equal to, little practical significance. This is the screen positive and the false positive rate, almost identical, 97%. So this is the screening design of how sequentially how of risk is being calculated. So a priori risk, like I said, every woman has a certain risk depending on their age and the gestational age. Then they're subjected to the screening, that is the biochemical markers. And there we get these absolute values of the beta HCG and the placental, the biochemical value, depending on the moms, and the likelihood ratios depending on the presence or absence of the nasal bone or increased NT or a ductus venosus or tricuspid valve regurgitation. All these put together, we will be able to calculate the post-test probability. So multiple markers, a priori risk into composite likelihood ratio is equal to patient specific risk for Down syndrome. This is the way it has been calculated. When to screen. So before I would enter this in the screening design model, like I said, a priori probability, every pregnant woman with a certain age has a certain risk, and then we do screening. So in the first trimester, screening is done in two steps. One is doing a laboratory where we give serum biochemical markers, where certain hormones, proteins are produced by the placenta, like the beta HCG and the papain. These, depending on these values, we will be able to get a certain risk for Downs and T13 and T18. And then they come back for an ultrasound. Ultrasound has certain markers like heart rate, then the nuchal translucency, which why do we call the NT scan? It's called the NT scan. So the NT scan is nothing but the fluid collection, the translucent fluid collection that we see behind the neck is called nuchal translucency. So depending on the measurement of the nuchal translucency, we will be able to calculate the risk for that particular gestation for that age. And then also presence of the or absence of the nasal bone is also looked for it. And tricuspid flow, the blood flow across the tricuspid valve in the heart, and the ductus venosus blood flow. All these markers are taken in the NT scan. When they're combined with the biochemical markers, we call it as a combined first trimester screening, and we will be able to calculate your first trimester screening. Apart from not only calculating the first trimester screening to help us to calculate the risk for Downs, the first trimester screening also helps us to date the pregnancy, and it is generally done between 11 to 14 weeks. That is where the length of the baby is. Sometimes patients come and they're like, they will not understand why we would have asked them to come back much later, because if the length of the baby is less than 45 millimeters, or if it is greater than 84 millimeters, we will not be able to give you a risk for the Downs or any of the chromosomal defects. So it is a very important criteria for the fetus length to fall between 45 to 84 millimeters. It has to be taken in a certain position. And apart from not only from ruling out from the chromosomal abnormalities, it also helps in detecting the chorionicity, which is a very important marker for the outcome of multiple pregnancy. That is also one more thing, and also helps us to protect preeclampsia because of the certain proteins that are being picked up in the first trimester screening. When to screen? Age-based screening. The different modules, like this is, though I said I would emphasize on first trimester screening, but I thought I would also cover what do we do in the prenatal screening. NT-based screening, where you do an NT scan and you look for the markers that I said for the length of the baby. And we also look for the fluid collection, that is the nuchal translucency, and other markers like nasal bone, tricuspid flow, and DV, along with the fetal heart rate. We will also be able to, apart from not only picking from the chromosomal abnormalities, you can also pick up certain early structural defects that are formed and can help the parents to take a better decision to continue or to terminate the pregnancy, depending on the severity of the structural defect. And then we do the double marker test, NT test, and we do a combined test. And we also add these additional ultrasound markers. Like I said, if there is any absent nasal bone or tricuspid regurgitation, that includes the first trimester. Second trimester, there are two tests we can do. One is a triple test or a quadruple test, and something called as a combined test, where a genetic sonogram, that is an ultrasound, along with the test, integrated test, we do a sequential screening. Which test to use? Relative efficacy, fixing false positive and comparing the direct risk, or fixing direct risk and comparing false positive ratio. So first trimester screening. So generally, when you used to start, they used to say every woman above 30 years need to be offered. Now we offer the test to every pregnant woman, because every pregnant woman has a certain risk of carrying a chromosomally defective baby. Blood test is done, looked for the PAPE and the HCG, and an NT screening test is done. Like I said, it has to be taken in a mid-sagittal position, and this is the fluid collection behind the neck, which is called nuchal translucency. This is the nasal bone, and this is the brain matter. And this is the section. This is an image showing the ductus venosus, that is the blood flow, and this is the tricuspid flow, that is across which is checked in the heart. So when you combine double test means when you combine your blood test, that is the double marker test. If you're just looking at it, the sensitivity or the picking of the risk is only 50%. When I combine my blood test along with the ultrasound markers, then the efficacy of the test improves to about 85%. And combined test with additional markers, like if we see any other markers that I've mentioned which are fixed and we see, then the efficacy increases to 90 to 95%. What are the serum markers? Like I said, is a free beta HCG, which is a placental product, and PAPE, which is also a placental product. What is the time to do the biochemical markers or the first trimester screening? 11 to 13 plus 6 days, or like I said, the length between 45 to 84 millimeters. Sometimes patients might come at 12 weeks, 6 days, because according to their early pregnancy, they would have come and they must have had some corrected date and they would have missed it, or they wouldn't have understood and they would have miscalculated and come. And when we see the fetus, it is only 43 millimeters, and then we can always ask them to go back and then come back for a scan. And ideal time to do the test is 12 to 13. Risk cutoff is 1 is to. We call the cutoff limit for the risk is 1 is to 250. Screening models: one is age based screening, one is NT based screening, double marker test, combined test, additional markers. Like I've already said, second trimester, the triple test, the quadruple test, and the genetic sonogram, which is in the second trimester with an integrated test, sequential screening, and contingent screening. These are the serum markers that we do in the triple marker. Is AFP, estradiol, HCG, and inhibin. When you include inhibin, it becomes a quadruple. These are the screening models. Like I said, in triple test, alpha fetoprotein, estradiol, and HCG is seen. The detective rate is about 60%. And when you add inhibin, that is in the quadruple test, the detection rate is about 65%. In Down syndrome, the fetal products are seen to be low and the placental products seem to be increasing. So for T21, the beta HCG is increasing, but for the trisomy 18 and 13, the beta HCG is decreasing. But however, the PAPE remains low in all the trisomies. So in trisomy 18 and 13, the AFP remains low in 21, 18, all the trisomies. However, the beta HCG seems to be increasing, which I've already told in trisomy 21, but it is low in trisomy 18 and not available for 13. The estradiol is low in both 21 and 18, and inhibin is increased in T21 in quadruple, and T18 is low. What is the timing to do? Okay, somebody has missed a first trimester screening because they must have not gone, or they must come for a scan when their CRL is more. Now they will not be able to do a double marker test or an NT screening because we will not be able to calculate. Those patients can be subjected to 15 to 21 week scan, where they can go for a quadruple or a triple marker test. The timing to do a triple or a quadruple is 15 to 21 weeks, or like I said, how the CRL between 45 to 84 for first trimester, the PPT has to fall between 31 to 52 millimeters. And the ideal time is 16 to 18 weeks. Risk, again, for the cutoff value, the risk value is 1 in 250. Genetic sonogram, direct detective rate is 56% just by looking at the ultrasound, and the false positive rate is about 3%. So this is a slide showing an ISWOG meta-analysis of second trimester markers for trisomy 21. No markers, likelihood ratio is 0.13, which is 7.7 fold. So these are the most common things that we see. These are certain things like echogenic bowel ventriculomegaly. Depending on each condition, that likelihood ratio also increases. Which, like I've already discussed, we finished the triple and quadruple. Let's talk about the combined, which is an integrated testing, which includes sequential screening and contingent screening. Integrated screening is where age is considered, ultrasound first trimester screening is considered, blood test is considered, along with that, a quad test at 16 weeks. So the detection rate is about 93%, and the disadvantage is failure to return for second blood test, which is a study done by Pandya et al. In 2007, but we don't follow. Contingent screening is a combined test where all the pregnant women that who had a previous Down syndrome or anybody above 35 years or any other doubtful cases, we do not subject through screening and we directly offer them a direct testing. All the low risk, maybe you think anybody falling between 25 to 30 with no other risk factors, no testing. This is how a contingent screening is used depending upon the places where no testing is done. Where an intermediate, where quadruple test is offered, where patients having high risk will be subjected to direct, and low to no testing and intermediate. So our set of patients do not fall into this contingent screening, so let's skip this completely. And this is sequential screening where two stages risk given at each stage. One is the first trimester, one is second trimester. This is also not we are following. So let's, which is the best? I would say the emphasis is late, the earlier, the better. So, first trimester screening is the best screening method that we have to detect chromosomal abnormalities at this position. Like I've already discussed, just by doing the blood test, we will be able to detect the ratio about 50% with a false positive rate of 3% for trisomy 21. By NT alone, that is the ultrasound scan alone, by 70. When we combine both the double test and the NT, the combined test, it is about 80%. When we add the additional markers, it becomes 90 to 95%, which still remains the gold standard for screening for chromosomal abnormalities. First trimester, like I said, is the best trimester, not only to detect chromosomal abnormalities and also help us to predict other structural abnormalities and the outcome in multiple pregnancies, and also the probable chance of pregnant women having preeclampsia can also be predicted. So this is another graph showing just by NT alone 70 and combined about 82. Combined with nasal bone is about 92. Triple is about 60 and 65. Maybe in places where, this triple test and quadruple test play a role in places where there are no experts to do first trimester screening or an NT scan, where just a blood test can be collected for high risk pregnant women. So this triple test, quadruple, and contingent screening will be useful for those people. Pick up when you do the first trimester screening, you pick up more and you pick up early diagnostic testing by CVS possible, so that when you pick up very early, you can do a CVS and see whether the baby actually has a chromosomally problem or not. And you have an optimum time for NIPT because you're doing it way earlier. And option, if just in case of the baby is chromosomally abnormal, has Downs or any other triploidy, you can also give them a choice of termination in the first trimester. Ideal timing for first trimester: biochemistry at 11 weeks, anatomy between 12 to 14 weeks, that is between 12 to 13 weeks. Where to do screening? Any accredited lab or software where quality control on a daily basis, regular audit is done, are good. And these are different audits and certifications that are needed to calculate. These are some of the things that are used across the labs, which can be used in the software for us to give calculated risk. Screening in multiple pregnancies. Okay, the screening in multiple pregnancies is slightly different from the screening from a single pregnancy. In twins, the first trimester, the NT and the serum markers can be used. Performance of serum markers is slightly poorer because sometimes because there is larger placenta, you cannot separate and give different mom values for one twin and different mom values, or the beta hydrogen papae for the other, because it is together, the values are higher. So, but however, like I've already said, you can also establish chorionicity, which is a very good marker which helps us to predict the outcome, plays a very good role in predicting the outcome of pregnancy. And second trimester serum markers are known less accurate than in singleton pregnancy. Uh, there is this article which says the results of these show that the cumulative evidence on the performance of the combined test in twin pregnancies is good. Nowadays, it seems to be the best first trimester available for twin pregnancies. The combined test provides some improvement over NT based. Before we would only do an NT based screening and not do serum biochemistry for pregnant women based because but now the combined test provides some improvement over NT based screening by decreasing the false positive rate. This is an article and published in 2017. Triplets and higher order multiples risk is directly based on ultrasound markers. Biochemistry has no role. Whenever there's a vanishing twin, no fetal pole or singleton, only NT and the NT scan has to be considered, and no biochemistry again. Does NIPT change the scene? Yes. Non-invasive prenatal screening, where cell-free DNA, like this is the gestational sac and with the membrane, this is the placenta connected to the baby with an umbilical cord, this is the free DNA from the placental vessels through the maternal blood. The fetal DNA enters the maternal blood, and when we take the maternal blood and look for the fetal DNA, we will be able to look for it. This is cell-free DNA, comes from apoptic cells derived from maternal circulation, adipocytes, and white blood cells, and fetal placental trophoblasts seen in the maternal. So combined test detection rate is about 92% and false positive rate is about 3%. But in an NIPT, the detection rate is almost 99.5% for Downs and 99 for triploidy 18 and 13. And the false positive rate is less than 1%. So, but why are we still offering a combined test to a majority than offering an NIPT? So ideally, we should be doing an NIPT for everybody and not have an NT screening is what they could ask. But it is very low cost compared to NIPT. It's quite expensive. So it is only restricted to people with high risk in the first trimester screening, or an a priori risk with a high risk are subjected to NIPT. And also doing a combined test, when you do an NT screening, not only it gives you the risk for aneuploidies, like I said, it also helps us to detect the other structural defects. NIPS as a first line test indication, like I said, it is offered to women above 38. Some people use it above 35, or a baby with previous trisomy, ultrasound findings that have an increased NT or an absent nasal bone, or any increased risk in the ultrasound finding for risk for aneuploidy. NIPS in twins. Yeah, the detection rate is about 98 to 98.2% and only 88%. And but the false positive rate is about 0.5%. So how do we interpret screening in IVF pregnancy? I think I've lost you guys. Screening in IVF pregnancies, it helps apart from screening for aneuploidies for dating, but because of increased HCG injections and donor cycles, it's the same. So how do we test? How do we interpret? So when we do first trimester screening, the risks are calculated depending on different parameters. Like I said, again, age, which is the a priori risk, and then the double marker test depending on the serum biochemical markers, and then the others the structure, and then depending on the ultrasound, the NT and the nasal bone and the markers that we see in the scan. So if at all, if the risk is greater than or 1 is to 250, we call it as high risk. We subject that to counseling and offer them an invasive testing. If it is less than 1 is to 250, we put them into low risk category and they just need regular. But people falling with between 250 to 1000 are called as intermediate risk, where counseling is offered. Instead of doing an NIPT, invasive testing, we could offer them a NIPT. Why do we have to do screening? So the secondary prevention. Whom do we do now? Like I said, everybody. It's a universal screening. What? Uh, what is it personalizes risk to? The reason doing it, why? Because it reduces the risk of having invasives. How? Filtering out normals and filtering in high risk. When? First trimester, second trimester, and combined. Which first trimester models? Where do we do it? In good accredited labs and softwares. Screening the larger picture, like I said, um, we have different types of screening where we pick up the high risk, the low. This is the high risk. This is the intermediate risk and the low risk. The high risk can be subjected to invasive testing directly. The intermediate can go for NIPT, and the low risk can just go for the regular antenatal checkups. And thank you. This is about first trimester screening. Just I think I hope I've cleared the most common doubts that generally people have during first trimester screening. The most common questions and are being covered. And a lot of people think that why I'm not really old, I'm not 35. Why do I need? I didn't do this for my first pregnancy. The idea of doing the whole first trimester screening is so that uh, we could exclude the risk and we could check the risk of baby having high risk probability for aneuploidies and offer only the women who are at high risk to further subjected to the next screening.